So thank you very much for joining this July the 6th alumni webinar. It's a pleasure to meet all of you. Thank you, first of all, of course, to Professor Yoko Kato and to my co-moderator today, who will be Dr. Thomas Tommy. Thank you so much, Thomas, for helping me. A special thank, as always, goes to Raja and Bunseng for their support with the logistics and not only the logistics, actually. Thank you, of course, to our two speakers today, Professor Ahmed Ansari and Dr. Filippo SInosi. We will introduce them soon. And thank you to our discussants, Dr. Sukirti Chawan and Dr. Biswas. So I think before starting, maybe Professor Kato, do you want to address some words to the audience?
Thank you so much. So I'm so happy to see everyone is so nice face. Maybe someone is in the morning and someone is in the evening. So anyway, but today's the two different field topic. It's very, very interesting, I think. So maybe it give us some a lot of the knowledge. Thank you very much.
Thank you, Professor Kato. Yes, I agree. Today we have two interesting topics. One is endoscopic spinal surgery, and the other one is new techniques for visualization before and during surgery for finding good corridors for our surgeries. So I think it's time to start. I would like to ask my co-moderator and friend, Thomas Tommy, to introduce our first speaker. Thank you, Thomas.
Thank you, Alberto. Good evening, good morning, every participants and panelists, and also Professor Kato for coming to this seminar. I would like to introduce the first speaker is Dr. Ahmed Ansari from Aligarh Muslim University from India. And he is, I think, very prominent in spine surgery and has written a lot of books and also journals with more than 50 publications. So to cut the time, so I would like to ask for Dr. Ahmed Ansari to start the presentation. Thank you.
Tommy, can you hear me in here?
Yeah, we can hear you
Yeah.
clearly. Thank you.
Yeah, it's so nice to see all of you in here. And it's my privilege to join in here. At the outset, I would like to thank Professor Kato, the organizing team of the Alumni Association, Alberto, Ishu, Tommy, all of you for inviting me in here. I would be speaking on biportal endoscopic spine surgery. I'll be sharing my screen here. Okay, so I'll be speaking on biportal endoscopic spine surgery, which has been a game changer in stenotic management as well as for spine patients doing the spine stuff. So as the name suggests, biportal endoscopic spine surgery, it utilizes two different holes for working for removing the pathology. One goes the endoscope, the other through the other hole it goes the instruments. So there has been a significant paradigm shift in endoscopic spine surgery, starting from the first generation that used the uniportal transfemoral approach to the second generation, which was basically an interlaminar approach for simple discectomies, to the third generation, which utilized either a uni or a biportal system for stenotic management, to the fourth generation, which utilized a uni or a biportal system for fusion surgeries. So this is a typical setup for doing a biportal stuff, in which one can see in here the patient is lying with the cranial side to the left, the caudal side to the right side, the instrument trolley, the video in front of the surgeon. The surgeon will be standing to the left of the patient. The C-arm goes from the front. So these are all the basic instruments that lies on the trolley. One of the most important thing is we use a radio frequency wand as well as a long shaft drill bit that is used in it. So what exactly goes in, how we exactly goes in a biportal stuff. So as it utilizes two different hole, there is no potential space inside the spine cavity. So what we do is there is potential space in between the two multifidus muscle. What lies exactly between the two multifidus muscle? There is simple loose areolar tissue. There's nothing else. So where do we exactly hit in order to reach out to our working space? We hit at the spinolaminar junction in between the multifidus muscle, in which there lies simple loose areolar tissue. We make our way from the spinolaminar junction going towards lateral side, towards the facet side, and clear all the tissues over there. Now, the potential space, this is the first space that we can see in the second picture, which lies when the camera and the simple instruments goes in. The third picture which you see is after the bony drilling. Now, once the drilling has been overtaken in here, there lies the actual true working space through which we have to remove and do all sort of work in here. Now, when we are discussing with a simple ULBD approach, that is a unilateral laminotomy for bilateral decompression, we need to understand where exactly our skin incisions should be. So the thing is, our C-arm, it lies exactly in the AP position. We draw basically three different lines. One is exactly at the midline, that is at the spinous process. The second line goes at the medial margin of the pedicle. The third line goes between the exactly in the, between the disc space. The fourth can be at the lower portion, the mid portion of the lower pedicle. So what we are seeing in here is our incision is in between the spinous process as well as the medial margin of the pedicle. It is somewhere between them. So we basically goes in a paramedian position just adjacent to the midline in order to do most of the pathologies. Until and unless we are doing with the fusion stuff in the lumbar spine, most of the pathologies can be dealt with this particular incision. The exact pathology has to be taken into scene whenever we are doing the incision thing. So in here, what we are seeing in here, it's the same thing. The first line is just it's a midline at the spinous process. The second is at the medial margin of the pedicle. The third, as we can see, that is the disc space. So this is the first incision that goes at the medial at the mid to the lower portion of the pedicle of the lower lamina of the lower body, and approximately 2.5 to 3 centimeters above it is our second incision through which goes the endoscope if we are standing on the left side of the patient. So most of these pathologies, whether it be a simple discectomy or a flavum removal, everything can be dealt with with this particular incision. Now it's of utmost importance to understand where exactly is the flavum. In almost all of these cases of stenotic surgeries, we just have to remove the flavum. There exactly lies the disease pathology. We don't have to remove every bit of the lamina. That is not absolutely considered any sort of surgery, I would say, any sort of decompressive surgery. So the superficial layer of the lamina, it goes from the underneath of the upper lamina to the above surface of the lower lamina. The deep layer, it goes underneath the upper lamina till the tip of the lower lamina. Beneath this would be the capillary layer, beneath which would be the dural layer. So this is how far can we reach with this ULBD approach. So if we are somewhere in between the spinous process and the medial pedicle wall, so our endoscope and the instruments goes from in here. So we can get clear from the ipsilateral lateral lasses, the central portion to the opposite lateral lasses till the foramen. This can be all cleared out with this technique. So as we say, everything is hard before it gets easy. The same goes with applying the Biportal stuff also. The first step, that is the incision marking, it's usually the hardest step. So removing the ligamentar flavum by the Biportal approach, there are two basic techniques. The first that is most commonly used, that is the end technique. We start our way, our surgeon is standing on the left side. We start our way drilling from the spinolaminar junction, drilling our way to the ipsilateral lamina. That clears the first step. We go move our attention to the lower side of the upper portion of the lower lamina. That clears the second step. We move in this way to the upper side of the contralateral lamina. That clears the third step. And then the lower side of the lower lamina. In this technique, we can drill out a simple portion of the lamina from the upper side as well as the lower side, and the flavum can be completely detached. The same goes with the other technique, that is the Z technique, in which we go from same side, we clear out the same side, upper portion of the lamina from 1, 2, then shift our attention to the lower side of the lamina. Now, this is a very simple thing. What you are seeing in here, that's a 4-5 disc, in which we can see that the drilling has been started from the upper side. We make our way to the central recess in the flavum, remove the flavum, the dura as well as the nerve root has been exposed, and the disc has been taken out. So what you are seeing over here is that's an L5-1 disc, a huge extruded disc in here. We use simple hook retractors in order to remove the disc portion over here. And once the disc has been teased out gently, we can take the help of all the open instruments that are being used in open traditional surgeries or microscopic surgery or in open surgery. We can take the help of all of that. Once this disc has been taken out, we can see the relaxed nerve root over here, which has been inflamed with this huge extruded disc. In here, what we are seeing in here is what you are seeing is again an upward migrated disc that has been taken out. This is the at the cranial aspect. You can see the exiting root. We don't have to go towards the opposite side. The whole of the disc space has been taken out. Now, this is a very wonderful picture in which what you are seeing, it's a nerve root. Now, this nerve root in here, what you are seeing, it's a nerve root which has been under tension due to the underlying disc material. Now, we go over the axilla, in the axilla and over the shoulder in order to remove this space. And in the final picture, what you're seeing is a completely relaxed root. We can totally move this nerve root in all the directions. That is a completely relaxed root. So these are all management option, which gives a very beautiful picture if you are using this particular technique. Now, this is exactly the final profile picture that one sees after a complete decompression. Right throughout the complete contralateral exiting root, we can see the ipsilated exiting root. If there is a disease pathology, a disc that has been compressing over the nerve root, we can remove it out. A whole relaxed cord. Now, this should be the final picture aim if we are doing a stenotic surgery. That is a UBE, ULBD, unilateral laminotomy with bilateral decompression. Now, what more can be done? You are seeing in here two different pictures. One is an L4-5 fusion technique. Lumbar interbody fusion has been done standing from the left side. The other is the L5-1 fusion that has been done standing from the right side of the patient. In here, what you are seeing is, so in L4-5, we can see that starting from we have completely decompressed the opposite side root coming towards the whole cord has been decompressed. We can see the ipsilateral exiting root has been decompressed in here. And then in here lies our interbody cage that has been sitting in between in the interbody space. Now, in here, what we are doing is we are standing on the right side of the patient. We are dealing with an L5-1 listhesis patient. So in here also, our exiting root is coming from above downwards in here. This is the lumbar interbody cage in here that has been placed in here, and the correction has been done. And through the same incisions, we can go in for an MIS pedicle screws can be placed in. So now, what is the actual technique for a ULBD? We start our drilling right from the spanolaminar junction to the opposite side. We drill till the level we reach the central recess in the ligamentar flavum. Now, once you will see in here the ligamentar flavum, the central recess has been reached. That would be a cavity. That means that we have reached in the epidural space. Now, once this space has been reached, we shift our focus to the lower portion of the flavum attachment at the upper border of the lower lamina. So in here, what you're seeing, that's the drilling that is being done, and the epidural space of the lower portion is being opened up. So once this space has been opened up, we use the wand in order to remove the flavum from the opposite side. We start removing the flavum from the opposite side, and then we shift our focus, removing the flavum from the upper side of the contralateral lamina. Okay, so this is the drilling that is being done of the opposite side, the contralateral side. We are drilling it out. Once this drilling has been completely done, we utilize a U-shaped technique. We start our drilling. The flavum is being detached from the lower portion, and we start to make our way through bilateral through both the lateral laces in order to remove the flavum. What you're seeing right now in here is the cutting of the flavum that is being done on the ipsilateral side. we remove every bit of the lemma of the flavum on the opposite side, and then we shift our focus coming of removal of the lemma of the flavum coming to from the opposite side. This is the same side removal. Once this has been done, we start undercutting of the lamina of the opposite side. So what you are seeing in here, that the flavum is being removed with the help of a Carrison punch, and we are now just reaching it till the level of the central defect, and this is the last portion of the flavum that is being removed. And once this has been removed, complete flavum can be taken out. Now this is called an en bloc flavectomy. This can be very very useful if we are doing a stenotic case, because one of the things that is of utmost importance is to understand that the dura can be attached to the flavum in cases of stenotic chronic stenotic cases, and either taking out the flavum in a complete in toto fashion, or the use the undersurface of the Carrison punch as a retractor in order to remove the dura before it comes into our punch. That is of utmost importance to understand. So once the flavum has been completely removed, we are seeing that this is the contralateral nerve root. This contralateral nerve root has started to come into picture. We can make our way to the contralateral nerve root, clear it out. This is the same side compression of the disc that has been that has been coming in here. We can remove this disc space. Uh, that disc portion can be removed, and we can just decompress the whole of it. So either an en bloc flavectomy or a piecemeal removal of the flavum can be done. Now in here, what you are seeing, the surgeon is standing on the left side. At the 12 o'clock position, you are seeing that is the towards the spinous process. At the 6 o'clock position, it's towards the facet side. 9 o'clock, it's cranial, and 3 o'clock, it's towards the caudal side. We are removing the flavum starting from the lower portion in a piecemeal fashion. The cord as well as the underlying capillaries has started to come into view. The one thing that you're seeing right now in here, it's the radio frequency wand. Now, the midline portion that we are seeing in here, that's the central midline dural bulge, the tenting in the dura that usually occurs because there's flow of water coming from the endoscope that creates this tenting. Now, these are the places where it is of utmost importance for us in order to be very, very much careful while using our punches. Now, these are the places where the dura can be held with the help of the punch, and it can be easily torn out at the central portion, as well as the place where the nerve root has been coming out. So we can either remove the flavum in a piecemeal fashion, as you are seeing right now in here. The flavum is being completely cleared out slowly and gradually. Once this has been taken care of, we can see that this is the ipsilateral root, and this is the disc space, which is slightly causing some compression over here. We can also clear the root from the opposite side. In just a second, you will see that the root has been coming out. And what we are seeing it right now in here, that there are two instruments going in. One is the hook, and another instrument, that is the disc forceps going in. So what we do is we have utilized a 3-instrument 2-hand technique. What we do is through the same instrument portal, we can place two different instruments. The nerve hook retractor, that's a very, very common thing to place in out. What we do is we place simple hooks inside the same thing, and the main function of this simple hooks is to it can gradually tease out the disc material, and that can be taken out. So what we are seeing right now in here is we can go towards the opposite side, remove the opposite side disc material through the same incision, the same fashion that we can utilize the microscope. We use this technique in order to clear out the roots from both the sides. The complete cord can be seen in here. The midline dural tenting can be seen in here. And this is the complete final picture right from the contralateral root. Whole dura has been decompressed. Coming towards the ipsilateral side, root completely decompression has been done. So this is another thing. This is an L5-1, a huge extruded portion of the disc material with the left side standing portion of the standing surgeon. So everything is exactly the same. We go between the multifidus muscle, that is a loose alveolar tissue. We make our way and try to make a C-shaped position. That is the position where we should be starting our drilling. I'll just show the C-shaped thing. So our drilling should start from the level of the spinolaminar junction. That's the C that should be visualized. This is the C that should be visualized. Now, once this C is visualized, that is the spinolaminar junction. We start our drilling right at the spinolaminar junction. and making our way towards the same side lamina drilling till we reach the upper level of the phlegm on that side. Now, once this has been done, it all depends what exactly is the disease that we are dealing with. If we are dealing with the stenotic segment, we need to make our way towards the opposite side. If we are dealing with just a simple disc herniation, we need to remove only that portion of the disc material. So that's the thing that needs to be understood. Now this is an L45 right side disc material in which the surgeon is standing on the left side of the patient. Now standing from the left side of the patient, what we do is we don't remove if it's an exclusive right side pathology. We still stand on the left side of the patient. We make our incisions to the right side of the spinous process in order to reach and deal with all the pathologies that are exclusively right side. Every step should be the same. We undermine the lower portion of the upper side of the lamina. This is what we are seeing is we are trying to make our way till the level of the central dural cleft that has been coming into view in here. Now, once this has been exposed, we have reached into the epidural space. Now, reaching into the epidural space, we can use the help of our Carrison rongers in order to remove the phlegm in a piecemeal fashion. In here, what we are seeing is we are removing the phlegm from the nerve root that can be seen bulging coming, the bulge that has been coming out, clearing the root. Now, what we employ, it's a phlegm sparing phlebectomy. Every normal structure should be tried to be rested as such. That's the basic essence of a minimal invasive spine surgery, whether one is doing a microscopic or an endoscopic work. We have to reach the disease pathology, remove the abnormal structure by minimal or no touching of the removal of the normal structures. That should be the essence of a minimal invasive spine surgery, whether you would be employing a microscopic or an endoscopic thing. So what we are doing is we are removing the disc material of the contralateral side while still standing from the left side. We're removing the disc material on the right side. Our incision is exclusively on the right side of this patient. Now, once this has been totally taken care of, what you are seeing is a relaxed cord would be start to come into view, and once this has been completely taken care of, we can do a simple annuloplasty. Now, this is particularly interesting. An L51 right side standing for a simple disc under local anesthesia. Now, we have started to employ local anesthesia also for plain discectomies or even for stenotic segment pathologies. Mainly, we employ these for patients with multiple comorbid conditions or even for patients who want to go home on the very same day. It's a very beautiful thing. The surgeon is standing on the right side. I'm standing on the right side. This is the C that I was talking about, and the drill that has been started at the spinolaminar junction. Now we need to differentiate which is a diseased ligamentous phlegm and a normal phlegm. Now this is a normal phlegm. So we need to understand and remove as little of the normal ligamentous phlegm as possible. Simple undermining of the upper portion of the lamina, as well as removing of as small a portion of the phlegm as should be done. It should be done. Now, once this is done, the important thing is if the patient is under local anesthesia, the minute you touch the nerve root, the patient winces under pain. So now once the nerve root starts to come into view, what we do is we simply stop the fluid flow and just place some ropivacaine over the nerve root and just wait for 2 to 3 minutes. Now, once we wait for the same, all our movements should be towards the dural side. It shouldn't be towards the nerve root side, and it's hanged up again. So what we are trying to do is we are just removing since the patient is under local anesthesia, we are trying to remove the disc material by placing our hook towards the dural side rather than towards the nerve root side. And we need to place to inject some ropivacaine while the time the nerve root has been exposed over here. So once this has been done, what you are seeing over here is this is the simple teasing of the disc material. As you can see over here, the disc material has been teased out, and this is a huge extruded disc portion. That's the soft disc that has been taken out. And now once the disc has been taken out, you can see the relaxed dura over here, the relaxed nerve root over here. Patient is happy, everyone is happy, no pain on the table, patient completely pain free, patient goes home in the next 3 hours. So this is all the more that we can do under local anesthesia as well. We can remove plain disc surgeries as well as stenotic segment surgeries. So all in all, what we can say is this is a beautiful technique, and whether a surgeon is a right-handed or a left-handed, this ULBD approach provides a wonderful technique in order to completely relieve the stenotic segment and adequate portal pressure, that is of utmost importance, and adequate hemostasis inside, that should be taken care of.
Thank you, Dr. Ahmed Ansari. I would like to invite the commentator for this session, Professor Ashish. Yes.
I think Dr. Ansari, if you can stop sharing, we can all see our faces and we can have a good discussion.
I'm just saying.
Okay. So, great. Yeah, perfect. Okay, because then we can see everyone. I do not have any experience in endoscopic procedures, but great presentation, and I know that you are doing this for many years, and you have uh, you know held workshops and live surgeries at various places. So congratulations. I think it takes time to build your expertise over the period of time. There are a lot of young neurosurgeons here who would like to know some of the basic stuffs, rather than I'll basically focus on some of the basic stuff on like how do you transition from microscopic surgery to endoscopic spine surgery. What is your advice for the young neurosurgeons who have no exposure to endoscopic spine and want to pick it up? How do you transition? How many cases you think you should go? And are there any other techniques which they need to master first before they start doing endoscopic spine by ULBD approach?
Yeah, thank you, Dr. Ashish. That's a wonderful thing. Now, one of the most important things to understand in here, that most of us, by the end of the residency, uh, for for people living in the subcontinent region as well as most part of the world, they are at least very well educated and well versed with the microscopic technique. Now, to understand ULBD, the unilateral laminotomy with bilateral decompression, that's the same technique that is being done under a microscope. So, under a microscope, what we are doing is it's an air medium, doing it with the help of a tubular thing. So it's an air medium. The suction that is being held in the left hand of a right-handed surgeon, it does the work of suctioning, and with the help of a right hand, you'd be doing most of the work, that is the drilling as well as removing of the phlegm. With the help of a biportal approach, again both the hands are being utilized. Now the left hand, in which a microscopic surgeon was holding his suction device, the endoscopic surgeon is holding his endoscope. Now, through the endoscope, there is one more thing that is flowing through it. That's the saline medium. Now, this saline works in the same way as the suction is working. As a suction is working in a microscopic patient that you're operating upon. This saline thing, it clears out all the blood, all the debris, all the bony material that comes into view. So the basic beauty about biportal thing is it's pretty easy for a good microscopic surgeon to transition over a period of, I think, at least around 25 to 30 cases, to become to go onwards to doing ULBD approach cases with a biportal endoscopic thing. So definitely there is a one thing, that is the economic situation that one has to understand, because a microscope is available at most of the centers. Purchasing an endoscope and then working it out and then taking out the financial burden from the hospital as well, it's another thing. Now that's the beauty where the biportal work comes in. Most of the instruments that we are dealing with are the same instruments that an open traditional surgeon would be working with, except for the endoscope, that is usually a 0-degree endoscope, an RF vent, and a long shaft drill. All the instruments are the same that we are using with a traditional open microscopic surgery. So learn a good microscopic surgeon, I would say it's pretty easy for him to transition into a biportal surgeon after quite a few number of cases. That's what I say.
Okay, thank you. And in terms of if you are holding the left hand, if you in the left hand you are holding the endoscope, the suction is included within the scope. Is there is a how do you suck the fluid out which you use to
No, the thing is, we need to
create the
create
space?
a fluid medium. So the
Mhm.
fluid goes from the endoscope portal and it comes out through the instrument portal. So there is
Oh,
no
okay.
suction anywhere. The fluid works in the same way as a suction is working in case of microscope. It clears out all the debris. That's the thing. So the main function of the two holes is through one hole goes the fluid, through the other the fluid comes out, and that should be a wonderful clear out medium. And there can be some complications also if it travels the intertransverse, and I have seen in some of the surgeons in which the fluid has passed into the retroperitoneal space and the patient had landed up into a very huge intra-abdominal pressure, and they have to relieve by opening the abdomen as well. So we
Okay,
have to understand how much fluid pressure that needs to be given to the patient as well.
thanks. And indications of how to pick your patients up, like which patients you will think like, oh, I should do an open surgery or I should use a microscopic surgery versus which patients are absolutely fine for endoscopic procedures. Like, how do you choose your patients?
See, right now, I think nearly for all types of patients with a degenerative spine, for acute pathology, for a fusion surgery, I'm going in for an endoscopic approach. But of course, for tumor surgeries, still still some people are doing small schwannomas in which we don't have to do much in there. Just open the dura, take the tumor out, cut the root attachment, and then seal the dura. Apart from the tumor thing, I think for almost all the pathologies, endoscopic work is beautiful. Patient can be Most of our patients are being discharged on the second on the first working day, or at max on the evening of the first working day. Most of the patients. So, given a scenario like ours in which there are the patient has to go back on his feet as early as possible in order to earn the bread and butter for his family. These are the wonderful. These are some of the most wonderful procedures, especially in subcontinent region. It's not that these are the procedures that should be exclusively held for the developed world. Our
Mhm.
the subcontinent people, they should be given advantage of these procedures the most.
Okay. And recurrent cases also, would you suggest endoscopic decompression if you have a patient with recurrent disc herniation or a recurrent stenosis?
For
What do
recurrent
you think?
cases, one of the best thing about the endoscopic thing is we land up at the bony at the bony junction. So we clear our space out of the bony thing towards the abnormal tissue. So that's where the beauty of the endoscope comes in. With a microscopic thing, or for an open surgery, you'd be either utilizing the same incision. For endoscope, we go a bit lateral side.
Okay.
So even if it's our endoscopic recurrence, I had two cases of acute disc with that had recurred within 10 days. That was very unusual, very unusual. I'd gone through the same thing. The disc was completely removed out, and the patient were discharged on the next day. So one thing to understand in all of these disc cases is there is one soft disc and the other is this hard disc. The amount of the annulus that has been opened, it needs to be sealed back with either the help of an RF vent, or even there are some endoscopic surgeons that are now utilizing simple sutures over the annulus, opened annulus. So one of the most important thing to understand is we need to seal the annulus back in its position with the help of an RF. If we are not sealing it out, the as the earlier surgeons were saying that we need to take each bit of the disc back out. The endoscopic ones are saying just remove the abnormal thing. Don't touch the normal ones. Just leave all the normal ones to its place. That should be the essence of endoscopic work.
So basically, you don't do the whole discectomy, you only remove the
Yeah,
sequestrated
yeah,
part
yeah,
which is
sure,
come
sure.
out in the canal.
Yes.
And last question is the risk of durotomy. Like, what's your risk of durotomy in your own practice? And how do you deal with the CSF leak, for example, when it happens during this endoscopic decompression?
Yes. So, Touchwood, I had one case of durotomy in my very early in my career, and I was very clear. If I had a durotomy, I had to shift the patient to an open thing on the table. So I had opened that thing. Right now, if a simple dural tear occurs, if it's a tear, if the tear is around 2 to 3 millimeter or around 3 to 4 millimeter, what the best thing is to place there are various dural substitutes that can be placed as an inlay graft over it. What we need to do is we just have to shift the fluid pressure, or to stop the fluid going in at that moment, we place the dural graft inlay under the dura and just leave it as such. The beauty there, as there is no seizure leakage, is that the skin incisions are very small, and there are very, very low chances of the CSF leakage if they are just plain small tears. Or if it's a huge tear, we can employ the use of staplers as well, that are very, very handy.
And glue and fibrin glue or something like that also can be used? Or
Yes, glue is a very good thing, but the thing is, as the fluid is continuously going in out, it gets washed out.
yes.
So
Okay.
taco seal is the best thing. I would say taco seal is the best answer for it. We can place that simple taco seal over as an inlay craft over it. Just as there's this Japanese craft, the origami technique, in which we just make an origami and open it up inside the dural space. It's opened out and it's completely sealed up.
Thank you so much. Amazing presentation, and congratulations again.
Thank you.
Thank you, Dr. Ahmed and Dr. Ashish. I saw Alberto raising his hand. Please, Alberto.
Yes. Well, Ahmed, thank you for your very nice presentation. You certainly have a great experience in this kind of surgery. I have one question and one comment. The question is about biportal and uniportal endoscopic surgery. So I have some experience with uniportal. I don't have any experience with biportal. I have the feeling that there is no, not perfect procedure or not a better procedure between them. I feel it really depends on the surgeon's skills or preferences. But I would like to have a comment by you about these two possibilities, so uniportal versus biportal endoscopic surgery. Do you think one is better than the other, or it depends on the situations or cases? And the comment is about the indications. Ashish already asked a question about that. But as these seminars are mainly for young neurosurgeons, I think that one message should be start with the easy cases, for example, but I'm talking about uniportal. I don't know if this applies also to biportal technique, but for uniportal, the easiest cases are for interlaminar approach, L5-S1, as you don't need to drill out the bone. You really go straight forward through the yellow ligament, the ligamentum flavum, and you get inside the canal very, very easily. So avoiding also probably the migrated herniations because it's not so easy to chase them within the canal. So I think these messages can be useful for those who want to approach this kind of surgery. Thank you, Ahmed.
Thank you, Alberto. As you have nicely picked out the indications, the same indication, the same thing goes with the biportal stuff as well. Starting a new surgeon, I would recommend going in for a left side L5-1. The interlaminar window for the L5-1 is the widest of all. As we go up, the window decreases in its width. So left side L5-1 is the one thing that you should be starting with. Going up, left side L4-5, that should be the second thing. L5-1, L4-5. Then we should start our focusing towards simple nerve root decompression stuff. And then finally, after we have done quite a few numbers of it, then shifting our way directly going towards the right side. Standing on the right side for exclusive right side pathologies, there's one most important side effect, or I'd say a complication, that is getting lost during endoscopic procedure. So that's fairly common in the early phase of one's career, getting lost inside the window, inside the endoscopic picture. So indications, well, you have picked out all clearly. ULBD procedures, I would say, going in after 25 to 30 cases, one should be picking up the ULBD procedures. Fusion surgeries still a bit late after that. Then comes the thoracic work, and then finally the cervical work. That in this fashion, I think a person should pick it up. Now, I've heard quite a few surgeons saying that biportal is still a very destructive form of surgery. Now, whether it be a microscopic surgery, a monoportal surgery, or a biportal surgery, one needs to understand that ultimately it's up to the understanding and knowledge of the surgeon to understand what are the structures that needs to be removed. Whether you have the microscope in your hands, a uniportal or a biportal stuff, until and unless a surgeon has the clear understanding how much bone has to be removed, how much flavum has to be removed, there will there will be a group of surgeons that would say that this particular surgery is better than that surgery because it's still more destructive than the earlier one, or microscopic would be better, or a monoportal stuff would be better. So all in all, what I would say, it all depends on the skills levels and the instrument availability, the resources one has in hand, in order to decide what form of surgery one needs to pick it up. Regarding the monoportal stuff, one of the biggest drawback, I won't say a drawback, the cost factor is a bit very high as compared to the biportal stuff. The instruments, everything that if it gets torn out, the purchasing rate, it gets a bit on the higher side as compared to the biportal stuff, as most of the instruments that we are using in the biportal, it's the same instruments that one uses in cases of open traditional stuff. So the cost factor, it's way down in cases of biportal as compared to the monoportal. Regarding the destruction, I won't say one to be superior as compared to the other. Biportal utilizes a very great degree of freedom in both our hands as compared to the uniportal starting phase. If one is well versed with the monoportal stuff, there is no problem with regards to the degree of freedom. But in the starting phase, biportal offers a great degree of freedom as compared to the uniportal.
Thank you, Ahmed.
Thank you. Dr. Raj Kumar.
So, first of all, I would like to congratulate the speaker, Dr. Ansari sir, who done a very good presentation. I'm from Bangalore. Currently, I'm a fellow at Fujita. So, I have two questions, sir. First is, what is your experience with spine, starting with, and after how many years of microscopic spine experience you started doing endoscopic spine? And second is, how many, is it only lumbar pathology that you're operating, or how many thoracic and cervical degenerative pathologies that you're operating? Thank you.
Thank you, Dr. Kumar. See, I started doing endoscopic work after I completed my training from South Korea. It was in 22, so it's around 3 years for me doing the endoscopic work right now. But we are a very high volume center, I would say. That we operate quite a good number of cases, with whether it be decompressive surgeries, whether it be fusion surgeries. We do operate it very frequently and at very huge numbers. And I would say right now we deal with almost all sort of degenerative stuff in the spine, all the acute stuff in the lumbar spine. Thoracic, most of the pathologies that we are dealing with is the ossified ligamental flavum, the OLF pathologies that we do fairly on a regular basis. Cervical is the lowest of all, as most of the cervical stuff that we are doing, it's either a plain lateralized cervical disc, or in a few, very few cases of cervical laminectomy, in cases of trauma as well, we have started. In cases of post-traumatic cervical compressive myelopathy, we can remove the whole of the cervical lamina, the compressed portion of the cervical spine as well. But they are very low numbers. So majority of the patients that we are operating right now are of the lumbar spine. A fairly good number of thoracic as well. Mainly those are OLF patients, and a few patients with cervical spine as well.
Thank you, sir. Thank you so much for your answer. Thank you.
Thank you, Dr. Raj and Dr. Ansari. Is there any more questions from the panelists? I would like to ask one question. So, in young neurosurgeon what's called with young neurosurgeons, I think because of the investment of machines and instruments required for UBE, for micros as for imagination that the price of microscope is much more than a tower of endoscope, and I think after I graduate, they start for single portal, dry field, and then came wet field and now biportal technique. Thank you, Dr. Ansari, for describing this technique. But what is the disadvantage of this technique or the contraindication for this technique? Because I see many young neurosurgeons now uh, using this technique because they can, not because of the careful indication or patient selection. Thank you.
Yeah, Thomas, very, very important comment that you had given. See, one thing is getting appropriately trained. That is one of the most important things to understand. Whether whoever is starting it out, it's not that if you have the instrument, you can operate on any of the patient, as has been the understanding of most of the of, of few people, I would say. It isn't that if you have the instrument, you should start doing it out. You need to understand what exactly is the correct technique, learn the skills, and then gradually start doing it from simple cases right to the complicated cases. If you're not following in this fashion, there are bound to be complications, half-hearted decompressions, and the patients are bound to land up finally into failed back syndromes. So this is usually what happens in most of the patients. Patient gets operated for one thing, the pain doesn't go away or has started back to the same portion or the other portion. He gets operated by another surgeon, half-hearted, whole-hearted. Then ultimately he lands up into fusion surgeries and then finally into failed back surgeries. So the primary aim of a good endoscopic surgery, it should be decompression. Fusion should never be the final aim or the purpose of an endoscopic spine surgery. If you can achieve a very good decompression, why go for a fusion? There are selective indications for going in for fusion surgeries, but that should not be the only indication that we have to place in screws and we have to place in cage. A good decompression should be our goal for in using endoscopic spine surgeries. Thank you.
Thank you, Dr. Ahmed. So because of no other questions from other panelists, so I return this session to Professor Alberto Felletti. Thank you.
Thank you, Thomas. Thank you again, Dr. Ahmed Ansari, for a wonderful discussion and presentation. We have to go ahead with the second talk. So our second speaker, as usual, is a young neurosurgeon. Dr. Filippo SInosi is a resident of neurosurgery here in Verona, where I also work. And although he is very young, he already has collected a number of experiences in Italy and abroad. He completed an Erasmus program in Finland. He extended his training also in Trento, Italy, and he completed a neuro-oncology observership in London and a research fellowship more recently in San Francisco in the USA. He published some papers already, and he has been a speaker in several scientific meetings and congresses. He has a special interest and also very good skills in advanced IT. And today he's gonna give a lecture about 3D morphometric analysis of microneurosurgical corridors with a novel open source tool. So thank you very much, Filippo, for sharing your research with us.
Thank you, Professor, and thank you, Professor Kato and all the panel for this opportunity. I've completed a fellowship recently in the skull base and cerebrovascular lab at the University of San Francisco. And I would like to share my research that we have completed in May, and it's currently on peer review. So our focus, I'm completely switching topic here because we go from spine to cranial. And our focus was to find a common ground for to find a way to conduct morphometric analysis of microsurgical corridors. In other words, we tried to standardize the current methods used to obtain some measures of neurosurgical corridors. And we all know that choosing the safest and most effective surgical corridor is crucial in neurosurgery. And recently, many anatomical studies have introduced some metrics that compare different approaches to the same targets. The current gold standard relies on sparse coordinates that take it with a neuronavigation system. And what we have at the very end, the final result, are irregular polygons with a limited amount of points, which are then analyzed all together. And for many years, and still today, researchers rely on two-dimensional metrics, defining the boundaries for instrumental maneuvers, such as the angle of attack, which defines the widest angle of the approach, or the surgical window, which represents the superficial limits of each approach. Only recently, some studies alongside the progress of technology, some research groups have started to compare three-dimensional metrics, and namely, this is volumes. But despite these improvements, pooling and comparing data across studies remains a huge challenge because every research group uses their own hardware, navigation systems, and software, so that they're often proprietary and that they're not shared among the community. So there's no common tool for us to handle these morphometrics in a consistent way, and we can't compare studies. We can't do meta-analysis. So this has been the primary motivation for us to develop something that can improve accessibility in neuroanatomical research. And since we've developed a tool to handle morphometrics in a 3D environment, in a three-dimensional environment, we thought it could be useful to validate this tool on 3D models themselves of surgical approaches. And to do that, you can do CT scans, you can do MRIs, but they're very expensive, especially in the preclinical settings in cadavers. So we used surface scanning techniques, which are cheap and relatively accessible technologies. We digitalized our approaches using either an industrial scanner, which is called structured light, or simple photographs taken with a camera. This is called photogrammetry. So we basically scan all around the object of interest. In this case, it's the approach, the surgical approach. And what we have, the final result, is a three-dimensional model, which can be stored and shared indefinitely. These models have been used quite a lot recently to improve neuroanatomical research, but no one so far has tried to either scan deep corridors towards microsurgical targets or to get meaningful measures on these corridors. So we aimed for two main objectives. First, we aim to develop a common ground to simplify and standardize this morphometric calculation. And this would allow to effectively collect pooled data and proper meta-analysis and studies comparison. On the other hand, we strive to understand if virtual models of surgical approaches can effectively capture all the fine details with enough precision and accuracy compared to the manual sampling of coordinates using the navigation system's probes. So we present our tool. This is called MorphoNeuro. It is actually an extension developed in a Python programming language, and it is made for Blender, which is a free generic purpose 3D modeling software. We have used Cursor, which is an AI-powered code editor. This was used to develop the code, to refine the code of the extension without having proper professional level programming skills. I'm a neurosurgeon, I'm not an engineer, software engineer. The extension is, of course, open source, so everyone can take a look and download it and test it on their computers. Blender is a free software, and it is available on all major operating systems. So let's have a brief look at the main features of this extension. First of all, the add-on can build and display surgical corridors by loading coordinates obtained with the navigation system, Cartesian coordinates, XYZ. And it can produce the same corridors when a group of coordinates is selected on 3D models. Additionally, and this is a novelty, it can also model automatic corridors. So in this case, the user, the researcher, only has to select one target, and then the tool calculates the boundaries of the corridor in an automatic fashion. Then, since coordinates lie usually on different planes, Morphy Neuro can also normalize the coordinates to a normal plane, for example, at a certain height, in order to enable meaningful comparisons across different approaches, for example. And of course, once we have a proper corridor, we can calculate angles, superficial areas, and volumes with just the click of a button. We have tested extensively the tool on 3D models as well. And for this proof of concept study, we have selected two common approaches, pterional craniotomy and an orbital pterional extension with the orbital rim, removal, orbital roof, and lateral wall of the orbit. We have selected two vascular targets that were consistently reconstructed using surface scanning. That is the MCA bifurcation and the ICA bifurcation. And the superficial coordinates were marked, so they could be seen on the 3D models. And the coordinates were first obtained with the navigation system. Then we did the same thing virtually on the 3D models using Blender and using our add-on. Eventually, we could perform the comparison between the two methods in order to assess their accuracy and their precision. So the results confirmed our hypothesis, and actually they went beyond our initial expectations. We found sublimetric precision for both photogrammetry and structured light scanning in linear distances. And overall, the precision metrics differences from the surface scanning and navigation were negligible across methods. So it is very precise. And accuracy was way better on the virtual models. This is actually expected because virtual models can be zoomed in indefinitely. So coordinates can be picked with far more accuracy than manual eyeballing with just a navigation probe. So what we have tried to do here is to simplify and standardize neuroanatomical research as much as possible. We strongly believe that science should all be about sharing findings, provide improvements for patients that go beyond personal or commercial interests. So we have released our tool for free. You can find the GitHub link here with this QR code, and anyone who's interested is welcome to test it, provide feedback, and of course, even improve the code if they want. It's all public, it's all free, that's open source. So, oh, I don't know what happened here, but second, we have demonstrated for the very first time, I would say, that surface scanning can effectively reconstruct deep microsurgical corridors with enough geometrical and texturing details to allow some measures calculations. And this opens up a lot of possibilities. For example, it allows labs without a navigation system to conduct the same metrics calculation. So low resource settings can also do this type of calculations. For example, we have used an iPhone 13, which is priced at about $300 at the moment to reconstruct this photogrammetry model. So it's very cheap. In a more visionary perspective, the fact that 3D reconstructions just using a camera are effective at calculating distances and volumes, and this might prove useful in the future for robotics. Robots, they will need we need some ways to map the surgical field, recognize structures, and also calculate distances between those structures. Or, for example, the volume for instruments and the volume allowed for instruments to conduct safe maneuvering inside of the corridors. So there are plenty of groundbreaking studies that have been published lately on the topic. And we hope that this work we can fit in and contribute to this growing pile of evidence in order to bring the field of neurosurgery forward into the far future. Thank you. Thank you very much.
Thank you, Filippo, for your nice presentation. I think it's a really interesting topic because it merges neurosurgery with new technologies. So I want to ask our commentator, Ashish Kumar, to give some comments or questions. Thank you.
Thanks, Alberto. Thank you very much, Filippo. It's a real good work, especially if you have a cadaveric lab and a setup where you can actually go and practice. I think there's a lot of data on 3D morphometric analysis and surgical freedom. I have always wondered in terms of uh, how it actually helps. For example, if you're operating in a patient or you're going to operate in a patient uh, for example, medial sphenoid meningioma, and you want to see if your pterional craniotomy in that particular anatomy in that particular patient will give you that much freedom, or you need a more extension of bone frontally or somewhere else. So, in short, like it's how do we actually correlate this data with actual patient whose anatomy may be very different than what we have been studying over cadavers? Very basic question. I do not have any other questions or comments.
Yeah. So for sure, it's different. It's different. The real anatomy is distorted. Cadavers have a different consistency depending on how you preserve the cadaver or all the latex injections, for example. This is just a proof of concept work, right? So it's it's providing a method more than the actual data to know if you are you're exposing too much or you're just enough. You're exposing just enough for that pathology. So by providing this, we try to standardize everything for the community because, as I explained before, a lot of research has been done, but all the studies that have been published so far, as you mentioned as well, the data is just there. It's just for that study, and it cannot be applied for in the clinical setting, for example. So if you have some common ground, if you have something that can be used even in the clinical setting, because for example, this 3D digitalization of the corridor, it uses just a camera. And there have been some attempts so far at also reconstructing surgical fields. They're not as precise because still there are some gimmicks with reflections, for example, the reflective surfaces, and the fact that you have to get a lot of pictures of the microsurgical corridor from different perspectives, different angles is time consuming, and it might not be feasible in the actual live surgery. But the evolution of these technologies points towards a 3D digitalization of just one picture, just with the camera, with just the microscope, for example. And once we have that real-time data that we can correlate with preclinical setting and with the clinical setting, then we have some sort of like common thing that we can blend and merge together and improve our patients' outcomes. And yeah.
Amazing. And are you planning to do a second set of future study on this once you are back, or you are trying to make a
Yeah,
second
so
study out of it in future?
yeah, so this is just the beginning, as I mentioned. I'm out of the lab at the moment because I'm back in Italy. But for sure, this experience has given me some skills that I'm looking forward to apply also to the clinical setting, and I'm willing to test it out in the future. I'm not the only one doing this. The San Francisco lab is one of the most advanced laboratories in this particular topic. But there are a lot of other labs that are working on this 3D technologies. So I think we're going to see a lot of this new research being published in the future.
Amazing. Thank you, and best of luck for the future.
Thank you.
Thank you, Ashish, for your comments. We have two colleagues who want to ask questions. I think the first was Dr. Al-Sadegh, which I will ask Professor Ashish Kumar to introduce. But as we follow the rule of women first, and actually it happens that this colleague is also the discussant, I hope Dr. Al-Sadegh will agree if I give the floor first to Dr. Sukirti Chauhan. Thank you, Sukirti.
Yeah, thank you, doctor. That was an excellent lecture. It actually, why I wanted to ask you this question is with reference to being a clinician and being a researcher. So all of us want to do research and we end up doing some kind of research. So do you feel, because you have done a fellowship and training in Finland, you have worked in the UK and then now with UCSF. So you feel that can a clinician really do this type of quality research, or should the researchers just focus more on the research and the clinicians do their job? Because I tried doing a stroke protocol, I tried doing a stroke research, and it got delayed and delayed, and I was highly dependent on a lot of people. And at the end of the day, my total number of patients didn't come so much, and like I felt like I'm incapable of doing research after that. So what is your personal opinion, being a clinician first and then doing detailed research with a proof of concept type?
Yes, it's excellent question. It's very difficult to actually do both at the same time. And if you want to do both like in a proper way, or like with a lot of care for the patients and with a lot of attention to detail for the research, I'd say it's for very few people. And for example, I had to stop doing any all clinical work for this fellowship. I just did research. I just focused on research, and I think we ended up doing something of moderately high quality, but I had to stop everything else. So it's really difficult to have both, to do both at the same time. And researchers should do research, and clinicians should stick to the clinic. That's my opinion. But probably there are some excellent researchers. There are also excellent clinicians, and they're superheroes. I don't know how they do it. But yeah, I think most of the people should just focus on one topic of interest and follow that.
I'm really happy that you also had the similar experience. So when you try to do something, it's difficult to balance. Thank you. Thank you for your answer.
Yeah, if I may add on this topic, I agree. I also many years ago had a basic research fellowship in a lab in San Francisco. And then when I came back to Italy, it was really almost impossible to keep working on both fields, basic science research and clinical activities at an acceptable level. But I also believe that, especially when you are a young neurosurgeon, a resident, it is very important to be exposed to such research, not with the aim to become, a researcher in the future. I mean, you can change your mind and do that kind of job, of course, but it's important to have this kind of exposure when you have the possibility to have, because when you get older, you have more patients, as you said, Sukirti, and you are more busy with clinical stuff, and you have to think about the patients. There is no other way. But when you are a resident or a young neurosurgeon, you have the possibility to also focus on research, on basic science research as well. And the aim should be to be able to have a common background when you get older, and maybe you have some ideas and you can share your ideas with basic scientists or engineers or whatever you want, and speak the same language they speak, so you can develop your ideas much faster and better with their help. Ashish, maybe you want to introduce Dr. Al-Sadegh?
Okay. Thanks, Alberto. Just before on that previous topic, I'll just say, like, it depends on where you are coming from as well. In most of the Europe and North America, you have a dedicated 1 year of research time during your residency. So everyone has to do it. There is no option, because in your residency you either you have to do a PhD or you have to do a master's. You have to do something in between, which is was it's an alien concept for us when how we got trained. But now that is where most of the research happens when you are a resident. So you get dedicated time for it, and then you join back your residency and finish your degree. But as a clinician, after you have finished everything, I think you need a lot of money and funding and a lot of support in dollars or money to have like at least 15 people in your lab working for you. So you develop a lab, and it comes with a lot of funding from different grants. So it's a process. I think, as you said, if you want to do it on your own, it becomes very difficult. You need to have a dedicated team for it, and that's why for us clinicians it becomes challenging. But there are surgeons who do 3 days of clinical work and 3 days of research, and they say that this is good for their work life balance, as well as they'll publish more, and they can do some clinical work. It depends on ultimately what do you want as a physician. And so that was on that point. Just wanted to share my insights. Elsa, I'd like to introduce briefly, and then you can probably take it over from me. So Elsa Deg is actually a medical student at University of Edinburgh and in UK, and he is very much interested in neurosurgery, and he's already doing his PhD at this point of time. But I would like to hand it over to him. He was here at University of Toronto for some time, and he's very much interested in learning uh, from everyone across UK, across North America. Also, I've asked him to join. I invited him to the webinar to see what we do on usual basis, to learn from these excellent speakers and international physicians and surgeons, so that he can have more exposure. I wanted him to meet Professor Kato as well, so that if he wants to go to Fujita for more experience in future, that will be a great possibility. So Elsa, why don't you introduce yourself and let the group know where you're coming from and what are your interests?
Yes, thank you, Dr. Kumar, for the introduction. So as you said, my name is Alsig. I'm a year 5 MB PhD student, so I've completed 4 years of medicine so far and just finished my first year in my PhD portion of my studies. My interests mainly lie in vascular neurosurgery, as well as brain tumor surgery, as well as research. So my research is focused on neuro-oncology, and I I think first thing I'd like to say is thank you all for the wonderful talks today. Thank you, Dr. Ansari and Dr. SInosi, for the wonderful talks. It's really nice to get exposure with the cutting edge of research, as well as clinical and surgical practice. And thank you, Dr. Catho, for organizing this all, of course. Um, I think my first question for Dr. SInosi is, in terms of the model you use to sort of generate these images where you can essentially plan your, sorry, essentially plan your surgical approach, are you able to, in these models, it's like it gives you an optimal sort of angle, sort of target of attack. Are you able to adjust this? So perhaps you have a group of surgeons working on a difficult aneurysm, for example, if they have different opinions on maybe it should shift more anteriorly, more posteriorly. I think that's my first question.
Thank you. Excellent question. Bear in mind that these models are surface scans from cadavers, so they are not used to plan anything before doing something. They actually some results of some exposures. So you expose your targets, your vascular targets, and then you scan them and you obtain the 3D model. But after this experience, I've had actually the same kind of like interest, like the same question for me as well. Can I use this for my patients as well? So I've recently come back to Verona, Italy, and I've tried this with DICOM reconstructions with some vascular case, MCA aneurysm that we've operated a few weeks back. And with the knowledge that I got from this experience, I could I could create a 3D model of this aneurysm, and also try to expose the aneurysm in different ways, like displacing the brain or drilling the bone in a certain way. And it is all done with very cheap software, with an iPad and with cheap software like $10 lifetime. It's called Nomad, and it's a modeling software. It's generic purpose. I mean, it's everyone can use it and try to learn how to use it. And I got excellent feedback from my attending, who was very delighted to have the anatomy of the aneurysm before actually coming in the OR, and being able to plan the trajectory, or if there are some vessels coming over the dome of the aneurysm, for example, was very helpful. So it's an emergent technology. It's something that not everyone is very well versed into using this, but I think it has some promise also in the planning of your cases. At the moment, I'd say that I would use this for patients' education. So to give a brief overview to the patient of what we are going to do, not very technical stuff, but I think it relaxes the patient. It gives the patient some extra freedom, free of mind. Once he knows that the surgeon has a clear plan to approach his disease. And yeah, so I think it has some promise, but it's very, very early to say if it's going to be helpful or not.
Right, I think that's incredible. And there are some groups I've seen down in London and in Leeds that have done the visualization that helps with sort of patients understanding their disease progression. So I think that's incredibly useful. And I think my second question is, in terms of your results, so you had then using standard MRI, intraoperative MRI, sort of neuronavigation. Do you think that your sort of control with your neuronavigation will depend on the surgeon experience? So if it was a surgeon consultant for 20 plus years as opposed to just finish their exit exam?
Yeah, actually, the navigation system, it's used to just get the coordinates. It's not used with any sort of imaging. So it's just used to get the XYZ coordinates in space, but it's not used with any imaging of the cadaver because it's too expensive to actually do a CT scan or MRI of the head. So that's I don't know, probably a better, like a more experienced surgeon would expose less probably, or displace the brain less, but it's a cadaver, so it's the consistency of the tissue is very different from the live surgery, from the live patient. So I was mentored by Professor Rodriguez Rubio, which is a neurosurgeon and has been in the lab for many years. So he certainly has he knows better, but you know it's just the coordinates. It's not done with any proper imaging of the cadaver.
Thank you very much.
No problem.
Thank you so much, Filippo, for your presentation and for the very lively discussion. Thank you to all the colleagues who contributed to this very active discussion. I think we can end also this second session of the webinar, and we can now ask the new fellows at Fujita Bantane Hospital to introduce themselves. So I kindly ask, I think there are a few of them. Probably the first one can be Dr. Raj Kumar. Can you please introduce yourself briefly? You have 5 minutes to tell us about your country and your research activities. Dr. Raj Kumar.
Yeah, yes.
Thank you.
Can you hear me, sir?
Yes.
Okay. Yeah. Good evening, everyone. I'm Dr. Raj Kumar from India. I've done my neurosurgery residency from All India Institute of Medical Sciences, Rishikesh. I finished my neurosurgical training in 2022 May. After that, I am working in Bangalore. So currently I work in a hospital called Brains, super specialty hospital. It's exclusively neurosurgical and neurological hospital. So we routinely operate all kind of cases in neurosurgery. Most of our practice is spine, and we're also doing endovascular interventions along with open vascular in required cases. And predominantly brain cases, the workload will be more towards oncology. So that is our overall practice. And I'm interested in cerebrovascular and skull-based neurosurgery and spine also. But my primary interests are cerebrovascular and skull-based. Currently, I'm working in Fujita under mentorship of Professor Yoko Katama. So I joined in on June 2nd last month. So it's been like 1 month. It's been a wonderful experience. I am seeing new things, new technology that's being used, especially 3D reconstruction of vessels in bypass surgeries, STMCA bypass. And most of the aneurysm cases here will be treated with web, which is new thing for me, which we are not practicing in India. So other than that, endoscopic brain tumor excision is also a new thing that I'm learning. So mostly I'm learning minimally invasive neurosurgery here, along with cerebrovascular. Thank you so much for the opportunity. And I thank especially Professor Yokokat for giving me this fellowship opportunity. Thank you. Thank you.
Thank you, Dr. Raj Kumar, and welcome to Fujita Bantane Hospital. Then we have Dr. Zhang Wei. Dr. Zhang Wei.
Hi. Hello.
Hello.
Hello, Professor. I'm sorry.
We
The
cannot see
camera
you.
on
We
my...
can hear you, but we cannot see you.
Yeah. So I'm very sorry. The camera is wrong. It doesn't work.
Okay. You can introduce yourself anyway.
Okay, thank you. I'm Zhang Wei. I'm a fellowship in Fujita Hospital. Study from Professor Yuko Kato. I'm from China. Now I'm studying endovascular treatment and bypass treatments for the patients with vascular disease. So I have been here for 1 month, so it's a good opportunity for me to study. I have got many experience from the study of this month. So I want to study and other skills. Thank you.
Thank you very much, Dr. Wei Zhang. Welcome you too to Fujita Bantane Hospital. And we have now Dr. Abhishek Kumar.
Thank you.
Can you hear me?
We can hear you,
Hello.
yes.
Respected professor, respected seniors, respected colleagues, my name is Dr. Abhishek, and it is an honor to share this international fellowship ground which I'm sharing with you. It's really an honor. I am myself Dr. Abhishek Kumar from Lucknow, and currently I'm working as an assistant professor in Dr. Ram Manohar Lohia Institute of Medical Sciences, which is located in Lucknow, and I am working there as an assistant professor. So I have passed my MCH neurosurgery residency from a reputed prestigious institute, SGPG Lucknow, and after that I am serving my I'm doing my assistant professor in RML Lucknow. So in my institute, I am mostly dealing with the cases which are due to the high load of spine cases and trauma cases. So I am usually doing on day-to-day basis more of spine and trauma cases. And also when I In elective OTs, I am doing cases of gliomas and meningiomas and all the routine cases. My areas of interest are cerebrovascular and neuro-oncology, also skull-based. Last year in 2024, I had done a 1 month clinical fellowship in Osaka Metropolitan University under the esteemed mentorship of Professor Tikeboto. And at that place also, I had learned a lot of microsurgical techniques. And I felt that when I went back to my country and when I applied these microneurosurgical techniques, which I learned in Osaka, I felt that it was a significant improvement in my techniques. So that gave me an idea to get more exposed to other places which are teaching international fellows more of microneurosurgical techniques. And having a keen interest in the cerebrovascular division. So I wanted to come to FHU Bantani Hospital under the esteemed mentorship of Professor Yoko Kato. And said I'm honored that she accepted me. I have done research on high-grade gliomas in my residency, and in which I had done a study comparing the extent of resection and what is the correlation with the survival outcomes. So that was my primary research, and I also did a work on insular gliomas, in which I had done a study on comparison between the transcortical and transsylvian approaches, which is I was comparing it, and it is yet to be published, but the extent of resection paper got published last year. I have also worked on vasospasm in subarachnoid hemorrhages, as there is a lot of aneurysmal SAH cases in our institute. So I've done that study. What are the predictors of vasospasm? And there was a study even with using of the drug dexmedetomidine. Using that drug, that study is also we are doing that study is in the process. And apart from that, my hobbies are I like to run, because I feel that when I run, it balances out my the tension, and it's a neurosurgical branch, such a stressful branch that I like to run, and it kind of balances me out. I also like to dance on Indian music, and I also love storytelling my kids. I have 2 daughters, and I'm a very happy person, and I love to tell them stories in the night. And I feel that in the neurosurgery, there should be a balance between your professional life and your family life, and everything. Everything is important. The family, friends, faith, and your work all should be balanced. And that's how I feel, a personal opinion, that you will be a good neurosurgeon. Thank you. Thank you for the opportunity.
Thank you very much for sharing your experience and also for very important messages which we all agree about. So I think Dr. Mohammed from Jordan is not yet at Nagoya, probably. Professor Kato, maybe he's not online, right? Probably he will introduce himself next month. Then I'm wondering whether Donatilla and Salam from Tanzania, who are nurses, are online. I know they also joined Fujita Bantane Hospital. So if not, I want to ask Professor Yoko Kato to give some final remarks.
So thank you very much for we heard a very nice the lectures. But I think still the pure endoscopic, the procedure of the spinal, the lesion, even the degenerative or tumor, still a little bit the distance. Maybe Ansari, maybe you can have a more hands-on or workshop, or maybe you can write some textbook. I think it's very, very important.
Thank you, Professor Kato. Thank you so much for your words. I also think that we learned a lot, really, in very different fields. So we can close this webinar. But before closing, I want to thank again a lot Professor Yoko Kato, who is our mentor and the mind behind these educational activities that we try to promote every month. Thank you to our speakers today, Professor Ahmed Ansari, Dr. Filippo SInosi, for wonderful lectures and very active discussions. Thank you to my co-moderator, Thomas Tommy, and to our commentator, Ashish Kumar, and our discussant, Dr. Sukirti Chawan. Thank you to Raja and you, of course, for their help and support, and to all the audience for joining. Thank you so much, and we will meet again in 1 month for the next Fujita Alumni Association webinar in August. Thank you so much, and have a great Sunday evening or morning, depending on where you are living in the world.